Okay, we'll be talking about IPPB, or intermittent positive pressure breathing. This video series will be in 4 parts. So IPPB is short-term or intermittent mechanical ventilation. It's a pneumatic powered device that's pressure triggered and pressure cycled. We'll talk about those terms more as we move on. So the history, it came out in 1947. It became really popular in the 70s, but there wasn't a lot of scientific use for it, and it became overused. We used it on everybody because we thought, as respiratory therapists, we thought this is great. We're getting more long volumes, but the AARC clinical practice guidelines came out and really taught us that it is not the first line treatment for lung expansion. So IPPB falls into the category of lung expansion, but our first line of treatment is going to be incentive spirometry. So IPPB then is used when patients aren't able to get the minimal volumes for IS. So the definition is inspiratory positive pressure to a spontaneously breathing patient as an intermittent or short-term therapy. So when we think about the need for lung expansion, those are things that the patient will be diagnosed with, such as atelectasis, if they need secretion clearance, or short-term ventilatory support, or for an aerosolized med. This can be given to or delivered to patients that have an artificial airway or non-intubated patients, just with a mouthpiece or mask. So if we break down that definition, it really helps us understand this better. So in IPPB, it's inspiratory. So the pressure is delivered on inspiration only, and then there's passive exhalation just through the natural recoil force of the lungs and the chest wall. So positive pressure goes in during inspiration up to a point where whatever pressure we have set is reached, and then exhalation begins. When we say positive pressure, we're delivering an increase in transpulmonary pressure gradient, which is again that difference between the alveolar and the pleural pressures, by delivering this positive pressure that creates a gradient for gas flow to come into the lungs. This is the reverse of normal, in that with normal breathing, we'll decrease our pleural pressure to create a larger transpulmonary pressure. So this graph helps us look at a little bit explaining these pressure differences. So this first picture here is under normal breathing. Under normal breathing, we have a negative inspiratory pressure that delivers this volume, that delivers that pressure gradient for gas to flow into the lungs. When we're delivering IPPB, which is shown in this second graph, we see this sharp spike up where we have a positive pressure that creates a pressure gradient for gas to flow in. There's the comparison again between the two. So this first one is what we do when we're breathing spontaneously or when a patient's getting incentive spirometry. They have a drop in pleural pressure where the treatment is more like the normal physiology of breathing. And so the gas, we create that pressure change and gas flows in. Whereas positive pressure here, we're increasing alveolar pressure to get that pressure gradient. So big difference between the two. The next term to understand is spontaneous. So the patient triggers or initiates the breath. When we use the term trigger, that's what is starting the breath. How does the machine know the patient's trying to breathe in? Well, the machine senses a slight negative pressure at the beginning of inspiration. Once that slight negative pressure is sensed, then the machine triggers to whatever pressure it has been set. So it starts to deliver a breath. Intermittent means we're giving these treatments over 10 to 15 minutes, maybe every 3 to 4 hours. So, this is 15 to 20 minute treatments. Sometimes, depending on the hospital you're at, these will run 10 to 15 minutes, but it varies. But it is intermittent. So we give a 10 to 15 minute breathing treatment, and then they go back to their normal breathing for 3.5 hours, and then we come back when their next treatment is due. Indications for Ippb are to improve lung expansion. So this is for patients receiving low volumes with incentive spirometer, or those patients that are not able to cooperate. Remember, with incentive spirometry, we really need a cooperative, coachable patient that's able to follow instructions. It's important to remember that there's no single approach to treatment that works best for everyone. We have to try different things for different people. Ippb is also part of bronchial hygiene in that it does help with secretion clearance, because if we can get a larger breath in, sometimes then they can cough out more secretions. It can be used as short-term ventilatory support, and the Ippb circuit is set up to be able to deliver an aerosolized medication. So in short-term ventilatory support, if there was a major disaster and we needed a lot of people ventilated and the hospital ran out of ventilators to use, they could set up an Ippb machine to provide ventilatory support. There are several contraindications, such as attention pneumothorax. The pneumothorax must be treated before positive pressure is delivered to the patient. In an elevated intracranial pressure, adding more positive pressure will elevate that intracranial pressure even more. If they've had recent facial, oral, skull, or esophageal surgery, delivering a high pressure to the upper airway could damage that surgery. And nausea is also a contraindication in that if we go at pressures over 20 centimeters of water, it can open up that esophageal sphincter and increase the likelihood of air going into the stomach, which will increase the chance of the patient vomiting. And if a patient vomits while the delivery of Ippb through either a mask or mouthpiece, they're going to have a higher chance of aspiration, where those vomitous contents are aspirated into the lung regions. Some of the hazards and complications are it can cause an increase in airway resistance and work of breathing in some patients that are sensitive to high airflows. It can cause some barotrauma in those patients with COPD where we're overexpanding already fragile alveolar units. It can cause some hypocarbia, so we can blow off too much CO2 because we are giving such high lung volumes. There's a risk for hemoptysis, again from the damage. It can cause some gastric distension. Again, some of the gas can be swallowed into the stomach. And it can decrease cardiac output because if we increase the intrathoracic pressure, venous return will decrease, and they'll have a decrease in the filling of the ventricles, and cardiac output is a function of rate and stroke volume. So as we decrease venous return, we decrease that volume coming back into the heart, which is going to decrease cardiac output. We'll talk about this with all aspects of positive pressure ventilation as we go through this. It's just important to know that it is a complication. The other big hazard really of Ippb is that the effects are very short term. They last about less than an hour following the treatment. So I discussed that this is an intermittent treatment, meaning we do it for 15 minutes and then we leave and don't generally come back for 3 or 4 hours. Well, the effects of the treatment, which are hopefully an increase in volume, don't have really long-term effects. They really just last about an hour. The other thing, like many aerosol delivery devices, if we're delivering a medication through the Ippb circuit, only a very small amount of the medication goes to the patient.